بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أنا دكتور أحمد عليان، Perfect Dent Operation Manager. هكون معاكم النهاردة إن شاء الله في الإيفنت اللي كلنا مستنيينه من فترة، وكلنا في الشركة هنا كنا بنعدله بقالنا فترة كبيرة، وهو Meet the EdgeEndo Experts. اسمحوا لي في الأول إن أنا هتكلم بقية الويبينار إن شاء الله وبقية الإيفنت بالإنجلش، وده لان احنا معانا بروفيسور جانلوكا جامبريني اللي متابعنا دلوقتي وهينضم لنا ان شاء الله بعد المحاضره الاولى. Hello everyone, Ramadan Kareem. I'm Dr. Ahmed Elyan, Perfect Dent Operation Manager. Today is an exceptional day in the history of Perfect Dent Company. We are celebrating the online launching for one of the best files in the world. It is the EdgeEndo files here in Egypt, only at Perfect Dent. As you know, this online launching is due to COVID-19 issues, but we hope soon that we can arrange a conference in Egypt and we meet together with all of our speakers. Meet the EdgeEndo experts will be in two webinars. Today's webinar will be the first webinar, and the second one will be next Friday, 7th May at 9 p.m. also with me and Professor Gambarini and the four celebrities Indo speakers here in Egypt. Don't forget to put your name in the comments and have the chance to win a 5,000 Egyptian pound voucher from Perfect Dent. Stay tuned, don't go anywhere. Okay, thanks for doctors sharing their these difficult cases, these tough curvature cases. Okay, and now with the first speaker for today is Dr. Mohamed Abd Fakhr, lecturer of Endodontics at ERU University. How are you, Mohammed?
I'm fine, thank you. Hope you're doing well.
I think it has been 1 year since we last met in the live show at Perfect Dent last year.
Yes, exactly. Hope this one will be great too.
Okay. How's Ramadan with you, Mohammed?
Going fine. Alhamdulillah.
Okay. Nice to meet you again and to join our event. Mohammed, as you know that every day we're facing a lot of difficult cases and a lot of challenging curvatures in our clinics. So we have to prepare ourselves as endodontists facing these cases. What do you think else can help you in the clinic beside your assistance and apex locator, files, magnification? What about you?
Clinical experience is very important in endodontic treatment and practice. Anything that anybody could think that is difficult, by time and by a lot of practice, it can become easy. So anything that anybody could think is non-manageable or difficult, by time, if you practice a lot and if you have a problem and try to solve that problem relentlessly, at the end, you will be able to find a solution to your problem.
Okay, that's great. Mohammed, as you know, our lecture title or our webinar titles is Managing Canal Curvature. So your topic or your lecture title is Don't Fear Curvature, Just Embrace Them. It's a very exciting title, I think.
Thank you.
Okay, now Mohammed, I'm going to join the audience and enjoy watching and listening for your lecture. Are you ready?
Yes, let's begin.
Okay.
I had a patient a while ago that came complaining of pain on biting. And this is the preoperative X-ray of the tooth. This is a mandibular first molar. You can see here that all the obturation is short. And there are multiple curves in this case. You can see a curve here, in that root, a curve there, and another curve here. So when you look at that case at the beginning, you start to think, is that case difficult or is it easy? Can I manage such curves or can I face some difficulties resolving this problem? So managing this case, you can start to think about some problems that might arise. Will I be able to bypass these blockages, or there might be ledges here? Will I break a file while trying to manage these curves? So we're going to explore today everything about managing difficult curves. So today, when we talk about root canal curves, we're going to talk about the problems that might happen if we are not able to manage such curves. The role of sodium hypochlorite in managing difficult curves, using manual files for canal negotiations during managing the curves, coronal flaring with curves, and finally the sequence of the files that we are going to use when we are managing difficult cases having severe curvatures. Now, starting with problems that might happen while you are working. What could happen while managing difficult curves? One of the most common problems is fractured files. If you have an abrupt curve, you might find a fractured rotary file while you're working. Even a regular curve, but a narrow canal with a regular curve also, a file might fracture while you're working. Other than that, you might encounter some ledges if the curve is a little bit abrupt or difficult. And these cases can be a little bit hard to manage and resolve. So,
but excuse me, your screen in the first slide, or you switch it? Because here we are seeing only the first screen. Do you switch the slide, or are you still in the first one?
Yes, yes.
So we have a problem here in the screen. Can you switch it with the mouse?
Okay. Switch like that?
No, we're still in the first slide. Yeah. Now it's switching to the second slide, the X-ray slide.
Okay, just a second. Did it change like that?
No, we're still in the same slide.
It didn't change either like that?
You are in the slide number 2, right?
Yes, I'm in slide number 2.
Okay, can switch to 3 and 4 to try that the switch is going on.
Did it work now?
No, it's not working. Can you close the screen and open it again?
Okay. How about now? Did it work?
Mohammed, can you please close it and share it from the beginning?
I did that, yes. It didn't work?
No, we're still in the first screen, in the first slide. You can use it from your PowerPoint. We will open the screen here, but you can shift from the PowerPoint. Don't make it full screen.
Okay, just a second.
No problem. بيقول لك
But is it clear now? Because I see that it is far away.
Okay, can you select number 2 slide?
It doesn't want to move on. Okay, how about now?
Yes, now we are in slide number 2. Try number 3. Yeah,
no, but
yeah,
I need, yes, just a second. But I need to go into full mode to so that it would work. Just a sec. Did it come like that?
No. You can go back to the last option.
But the animations won't work.
Yeah. This is number 2.
Just a second. Can I choose something else other than the window and the option? And the sharing option?
No, I think the window is the best option. You can move smoothly on the slides. Don't open the full screen.
The animations, Ahmed, won't work. The pictures won't work. I need to move them. Did it work like that?
No, it doesn't work.
Okay, just a second. Did it work like that? Didn't work either?
No. Mohammed, can you try Alt Tab until you choose the full screen?
How about now?
Now it's okay. Move to slide number 2.
Yes. Now you're right.
Yes. Okay, so it is not the option of the second window. It is the first one, the entire screen. Okay,
no problem.
Okay. So sorry for that, everyone. Okay, we're going to start now again. Sorry for this technical difficulty.
No problem.
Okay.
No problem.
Okay. So let's go in. Let's start. Okay, so as I was just saying, I had a case a couple of while ago, this patient was complaining of pain on biting. When he bit on his lower first mandibular molar, he had pain. This is the preoperative X-ray, as you can see here. Now, if you look at this X-ray, you would find that all the obturation is short. Other than it is short, you can see that there are multiple curvatures there. There's a curve here, a curve there, and another curve here. This mandibular first molar has an extra root, an extra distolingual root, radix entomolaris. So when you come to think about solving the problem of that case and retreating that tooth, you start to think whether these curves apically, are they difficult or are they hard? Would you encounter some problems while managing that? Can a file fracture? Will you cause a ledge? Will you be able even to manage the curves from the start? So today we're going to talk about how to manage these abrupt curves and get a solution to a predictable treatment. Now, today when we're talking about the root canal curves, we're going to state the problem first that might happen if you are not very familiar with managing root canal curves. And then we're going to talk about the role of sodium hypochlorite during managing root canal curvatures, using manual files for canal negotiation and curves, using coronal flaring when managing curves, and finally the sequence of rotary files that you are going to use in acute and severe curves. Now, starting with the problems that might happen. One of the common problems is that a file might fracture while managing an abrupt or an acute curve, whether it's an acute curve or even a regular curve with a narrow canal. A ledge might be present. You might see that an inability to manage a curve can result in a ledge apically, and its management could be a little bit difficult. So these are problems that you might face. Now, starting with things that will make your life much easier when managing root canal curves, we will start with the sodium hypochlorite and its role and its help to aid you in managing such problems and curves. Sodium hypochlorite, I always say that I call it that it's a magician, really, because some cases that are very difficult, with the aid of sodium hypochlorite, it actually makes it a lot easier. So after you perform your access cavity preparation, you will start to use sodium hypochlorite as an irrigant. Now, sodium hypochlorite dissolves pulpal tissue, and we all know that its action is it dissolves the pulpal tissue very well. So pulpal tissue is comprised with collagen fibers. Collagen fibers are very stiff and very hard. So when you use a file to try to negotiate the root canal, you might find that the file cannot negotiate the canal well at first due to the resistance of the pulpal tissue itself and with the densely packed collagen fibers that are present. So sodium hypochlorite will start to dissolve and eat the pulpal tissue and ease your penetration more. The collagen fibers are packed more and they are more dense towards the apical 1/3, meaning towards the curve that is present apically. So this will provide a more difficult situation for you when managing the case. So I personally use full concentration sodium hypochlorite while I'm working in such curves. And bear in mind that if you're working in an older patient, meaning when we age more, the collagen fibers that are present in the root canal are more densely packed and they are much more in number. So you will need to use the sodium hypochlorite when you are starting your root canal preparation. It's very important. Now, as the degree of the root canal curvature increases, the amount and volume of the irrigant reaching the working length down there decreases. So you should also bear in mind that when using the sodium hypochlorite, at first the sodium hypochlorite will not reach the apical 1/3, especially in cases with curves. So you will need to continuously replenish the sodium hypochlorite. You will need to continue and irrigate every and each time from the start of your procedure until the end. And of course, you will need to activate your irrigant. Irrigant activation is very important in order to allow the movement, the up and down movement of the irrigant in order to reach better to the extremities and the curves of the root canal. Now, as we said, I want to irrigate here the root canal, use the sodium hypochlorite, and I want the irrigant to start to dive apically in the coronal portion of the canal, middle half, until it reaches the apical 1/3. What I'm going to say now is very important. There is a little bit of a misconception when using irrigants and lubricants in canals while preparing them. A lot of people say, when I'm going to prepare the root canal, I have a severe curve, then I will need to use a gel. And this gel or lubricant paste, I might use it with EDTA, which is a common component. EDTA is a chelating agent that dissolves dentine a bit. So I'm going to use this gel or cream in order to soften dentine and be able to manage the curve more. While actually, according to the literature and a huge bundle of studies, that managing severe curves needs the aqueous solution of sodium hypochlorite, which we already know now that it dissolves pulpal tissue and dissolves the collagen fibers. So sodium hypochlorite should be used instead of paste lubricants when using naked titanium files in order to reduce the stresses on the rotary file, because gels and paste forms that are used with rotary files in acute curves, they result in greater stress on the rotary file, greater torque on the file, which might result in the file being fractured or broken. And other than that, the file itself, it cuts more readily and better than any gel or paste that is going to be used. So sodium hypochlorite is your friend. You need to use it while preparing the root canal, and in severe curves, please avoid the EDTA or gel creams. Now, increasing the temperature and concentration of sodium hypochlorite will improve its digestive capability to the pulpal tissue, and it will allow you to penetrate the root canal better and more readily, along with activation of the irrigant. Now, after using the sodium hypochlorite, you will start to negotiate the root canal. When negotiating the root canal, you will start with manual files. Starting with what file should you use when negotiating an abrupt or an acute curve? I hear a lot of people using, they say, I'm going to start with using a K file size 15. Now, file size 15 is a large file. When using a manual file, start with using small files. Sizes like size 8 or size 10, because file 15 is a large file for the beginning of canal negotiation. Now here, this is a file 10. When you enter or place the file in a curved canal and get it out, the file commonly will have the curve of the root canal that is present. It will show you as if it's an impression of the anatomy of the root canal. You will see it. So it will give you an insight about the curvature that is present in the root canal. This is very important. So you use sodium hypochlorite, and then you start to negotiate and create a glide path away within the root canal with a stainless steel file. Now, beginning, you're going to use a 10K file, okay, which is stainless steel, not nickel titanium, because small files like size 8 and size 10, if they are nickel titanium, they cannot negotiate the root canals very well. So use stainless steel manual files at first with the small files, and negotiation with the manual files is extremely important in the cases of acute curves. Now, this is a systematic review that has published last year in 2020, seeing the literature about the influence of negotiation glide path and coronal flaring on the root canal. It is very astonishing to find that negotiating the root canal and creating a glide path away within the root canal decreased the procedural errors greatly, meaning that negotiating the root canal at first very well and creating a glide path decreased fractured files, ledges, blockages, and so on and so forth. So it is very important to create a negotiating path with your small files at first. Now, let's take a look at this picture on the left for this file size 10. If you have a look here, you will find that the curve of the file, this is beginning a negotiation of the canal and the file getting it out of the root canal. You will find that there is a curve in the middle half of the root canal, meaning here that the curve starts at the middle half of the canal. Here the curve is a little bit more apical. So you know here that you have the curvature a little bit directed and starting at the apical 1/3 of the root canal. Now, take a look at this picture. Now, if you take out your file and find it with this type of anatomy, because as I said, this file at the beginning of the negotiation, it gives you some insights about the shape of the root canal. Here you have a curve here, an abrupt curve here, and an abrupt curve there. So this is a very difficult case when you're going to start to manage. So take care, be careful. This is a difficult case. This is not an easy one. So you will start to use everything in your knowledge, and you will be cautious when working in this particular case. Now, you use sodium hypochlorite, you negotiated the root canal with your manual files, With the small files, we said you can start with file size, K file 8 and 10, and then comes the very important step, which is the coronal flaring. Coronal flaring, you can flare the coronal portion of the root canal with a rotary file, with an orifice opener, for example. Now, you flare the first part, the first curve of the root canal, this part that is highlighted here. You're going to flare it, okay, in order to make this initial curvature a little bit straight, okay? So in order to reduce the stresses on the file while entering and create a pathway to the apical part of the root canal. A clinical tip here, when just starting in an abrupt curve, preparing or flaring the coronal 1/3 of the root canal, do not, in the flaring period, do not go apically more than this coronal curve. Don't push the file apical to the first curve that is present coronally. Why is that? Because if the file that you're going to use to flare the coronal portion of the canal enters from the coronal portion and then enters into the apical curve and gets locked a little bit, it might fracture in the apical curve. So at the beginning with the coronal flaring, just stay up there in the coronal portion of the root canal to flare it. Now, here this systematic review, it saw the effect of pre-flaring, this coronal flaring, on the procedural errors and the preparation of the root canals when they are curved. They found that coronal flaring reduces the procedural errors by amount of 60 to 70%. Meaning that if you flare the coronal part of the root canal, this coronal curve, well, it will reduce the procedural incidence by an average of 60%, which is very good. So again, as sodium hypochlorite, as said, is your friend, coronal flaring also is your friend. It is a dear friend of yours when you're preparing curved apical canals. Now, moving on to the sequence in severe curves. Let's go and see what are the files that we are going to use step by step. This is a case that I had a while ago, and we found that there is a 360-degree curve there. This is a difficult curve to manage. This is not an easy one to manage there. So we are now going to use the sequence that we have used in order to prepare such a 360-degree curve. The first thing we are going to irrigate with sodium hypochlorite, as we said. I use full concentration, in this case, full concentration sodium hypochlorite to dissolve the pulpal tissue very well. Following that, we're going to start negotiating with a K file size 8 stainless steel K file. After that, negotiating with file 10 to create the pathway within the root canal, the glide path. After that, we're going to start and do our coronal pre-flaring. We're going to flare the coronal curve of the root canal to straighten it a little bit. After the coronal flaring, we are going to take the working length by file 10. We didn't take working length at the start. We took it after we flared the coronal portion of the root canal. Why is that? Because the working length is more accurate after the coronal flaring. After flaring and straightening this coronal curve, the working length here is much more accurate. So you're going to take the working length after flaring the coronal portion of the root canal. After getting the working length and reaching the full working length with file 10, you will enter with file 15 and reach the full working length. Can you see here, when did I use file 15? After using multiple files. So file 15 in curves, it's a large file. You cannot use file 15 at the start in a curved canal. Large file 15 is a large file. After reaching the full length with file 15, now here comes the attempt to enter with a rotary nickel titanium file to the full length of the root canal. However, the taper of that file would be a 0.02 taper to further enhance and enlarge the root canal and enlarge the glide path of your root canal curves. Okay, so here you want to reach the full working length with a rotary niti file using a taper of an 0.02 taper. After that, you will enter, irrigate of course, and enter with file 10 again to the working length to avoid any blockage or any debris from presence within the root canal. After file 10, you're going to enter with a K file size 20. You can see that you're using a lot of manual files. Manual files are very important in these abrupt curves and acute curves. After using the file 20 manual files, we're going to enter with the rotary file size 20 with the taper of 0.04. Now here, we increase the taper and use the taper of 0.04. In these curved canals, my recommendation is avoid using larger taper files more than that, because greater tapers than the taper of 0.06 reaching to the full working length, you will cause probably an error. The file might engage in the curve, it might fracture, or it might cause a ledge while preparing the canal. So in acute curves, use a taper maximum of 0.04. And if you want, you can increase a little bit and reach with a 25 0.04 tapered rotary night high file. And as we said before, that you will need with your irrigation along all this path, you will need to activate the irrigant a little bit with different sources of techniques of irrigant activation in order to allow it to reach more the apical 1/3 and to disinfect the root canal better. Because here the taper is not that large, so you will need to activate your irrigant. And now there are a lot of techniques for irrigant activation and devices in order to activate the apical, the sodium hypochlorite that is present in the apical 1/3 of the root canal. If you remember, this was the case that we started today talking about, the patient that had pain on biting. This is after finishing and using the sequences that we said before about the managing such abrupt curve. And we need to remember something, that straight roads do not make skillful drivers. And as such, curved canals will make you a better practitioner, a better endodontist, and you will strive to reach excellence after that. Thank you. This is my Instagram account and Facebook account if anybody in the future needs any questions or any references of any kind. Hope you enjoyed the lecture. Moving to you, Ahmed.
Thanks, Mohammed, for your efforts and for your lecture. Brilliant as usual.
Thank you.
I saw the difficult case, which the canal, I think, was dancing there.
Yes, yes.
And also the 360-degree curve, I think it's a very tough case.
Yes, yes. But as I was saying, when you work in these cases a lot and try to solve problems, of course you will face some problems and you will face difficulties, and you might even need to prepare the case that is with a severe curve more than once. To see the patient, I mean, you do not have to finish it in a single visit, for example. You do not need to stress yourself in order to finish it quickly or anything. You will need to take your time while preparing such cases and have some patience.
Of course, experience will add value for any endodontist. You know, after watching this lecture, I would like to go back 10 years old and become one of your students.
I'm humbled by you.
Okay, thanks, Mohammed. Now we are going to join with Professor Gianluca Gambarini, live from Rome, Italy, but just after this small report about him. Stay tuned, Mohammed, don't go anywhere. Hello, Professor Gambarini.
Hi, nice to meet you.
Yeah, nice to meet you too. Here's Dr. Mohamed Fakhr, lecturer of Endodontics at ERU University. I'd like to introduce him for you. What a great lecture. What do you think, Doctor?
Yes, very nice, very interesting. There's a lot of things we share together.
So, thank you.
Yeah.
Okay, Professor, what about the report? What about the Tarantella Neapolitana? Did we good a great choice?
Actually, I'm from Rome, but it's okay.
I think it's one of these.
You have music from Cairo or Alexandria. It's a little bit different. It's a little bit of competition, but that's fine.
Okay. What about COVID-19 issues and traveling?
Traveling is no good. Not a lot of tourists here. In Rome and Italy, very little. But we are struggling to get out, and we are doing well now. So we hope that next May we reopen everything. At university, we reopen everything, but in normal life, restaurant reopened just a few days ago. So everything is starting again.
Okay, and what about vaccine, doctor? What do you think? Did you take it?
I take it in January because I'm working in a COVID hospital also, apart from private practice. But now it's 25% of population is vaccinated, and they're aiming to reach 75% before the summer. So that will be much good. But let's say better. We hope. Let's say we don't know, but we hope.
You know, I'm just waiting to see the victims of the vaccine. But one day I will take it for sure because of traveling issues.
Yes. In Europe, they're thinking to make a passport for the vaccine. So when you show this, you can go everywhere in Europe.
Okay, I hope all of us be in good health. So we have to stay safe in order to. Okay, Professor, now your lecture will be managing of canal apical curvatures with more synthetic files.
Yes.
Are you ready, Professor?
Yes, I'm ready. I can try to share the screen.
Yeah.
I'm share the screen. I don't know if no. I don't know why it doesn't allow me to share the screen. Can you give me permission?
You can press the share option in the bottom, doctor.
No, I already pressed, but I think you have to give me permission because it's okay. I will try again. Share screen. Okay. Do you see now?
Yeah, doctor, we can see it now.
Okay, can you see the first slide?
Yeah, you can start, doctor, now. Okay.
Perfect. I follow Dr. Mohamed lecture, and I really appreciate it. There's a lot of things in common, so I will try not to say what he already said. But actually, I was speaking a little bit more about the instrument that we have to choose in complex curvature. So we know the ideal properties. We need the flexibility to go inside the canal and not negotiating complex anatomy with no iatrogenic errors, meaning that we don't want to make ledges, so we don't want to make zipping, we don't want to make canal transportation, we don't want to make blockage. And when we do the treatment, we see a lot of cases that fail because of this. And one of the major failure was because they choose the wrong files, not the good ones. And also sometimes we may find that breakage of the instrument. That's why between the ideal properties, we need resistance to fracture. And that's very, very fundamental properties. And as Dr. Mohamed also said, we need the cutting efficiency, but I would also add something, cutting efficiency and debris removal, because actually the cutting efficiency itself, it's not enough if you don't remove the debris that we create when we cut. So as a matter of fact, for many, many years, for 20 years, the major feature for the NITA rotary files was the design, because the design affected all the properties of the nickel titanium rotary files. But currently what happened in the last years has been a dramatic change in this. What has become a major feature in the endodontic rotary instrument has been the manufacturing process and the fact that you're making heat treatment before, during, or after the manufacturing process. And to be very honest, if you ask me if this is an important thing, I would say is a fundamental thing, because the heat treatment now is becoming a major feature in determining night eye performance. And this is not really well explained, and so the dentists get a little bit confused about what they are using and why they should use like this. The reason why night eye heat treatment is so important, because when we manufacture night eye, which is a very sensible alloy to heat, what happens is that during the manufacturing process, we create a lot of heat and we create a lot of internal damage, also external damage. But I'm speaking mostly on internal defects, the defects on the crystals. So if the crystals are damaged, they are not resistant, so the night eye alloy is not so resistant, and they do not flow easily. And actually, so we have an instrument that is not as flexible as we should want. So when we do a heat treatment, actually, the very thing we do is that we restore part, if not all, the initial good properties of the night eye. So we make a much better instrument than after the grinding process. Just to make, if you have a rough idea of what we can do, I'm showing this article we published last year in Applied Science, and we evaluated the stiffness of Pro Taper versus Edge Taper and Pro Taper Gold versus Edge Taper Platinum, which are the, heat-treated version of the files. And this is stiffness. So the higher the value is, the more stiff is the instrument. In the traditional alloy, you see the values for the S1 and the F2. But when we go to the heat treatment, then you see we have an incredible increase, more than twice, of the flexibility of the instrument. And this happens for the dense ply heat treatment and the firewire edge heat treatment. And if you want to be giving a little bit more data, with dense ply treatment, we can increase the flexibility a little bit less than 2 times. With the firewire, we increased approximately 3 times the flexibility of the file, which is a huge improvement. So when we speak about management of an apical curvature, we have to understand that these are the same instrument in the design. We may do something very different if you use an austenitic, more rigid, traditional file versus a new, more flexible and ductile martensitic file. As a matter of fact, the heat treatment does affect quite a lot of performance. So the traditional austenitic files, has a very high elastic return. So when it comes out from the canal, it has the initial design. But when we have a martensitic file, we know that it can deform, and we can also pre-bend this file. And you will see that this is a very useful thing when we deal with complex anatomy. Having said this, this is the file I'm using nowadays, which are the Edge file X7, and they are very peculiar because of the very specific firewire heat treatment, but it's also very peculiar because they have a smaller working part and a final diameter of only 1 millimeter. And it's a taper 04, which I prefer, and it's also available in taper 06. But what is very important that this is a very, very peculiar file, which is, in my opinion, great for complex curvature. And the reason why I'm saying this is that I showed you before the Edge Taper traditional night eye, the Edge Taper Platinum heat-treated night file. So we had an increase of 2.5 times. And with the X7, because of the design, because of the dimensions, here we have the same size 25 file. We have a much better increase of the properties. And the other interesting thing about flexibility is one is flexibility, the other one is elastic return. So we have, with this martensitic file, we have less bounce back. What does it mean? It means that when we go inside of the curvature, the files respects more the anatomy. And so we are able to deal with very, very complex apical curvature, sometimes even with very abrupt curvature, in a much better way, in the sense that we respect the anatomy with less canal and apical transportation. And this allows us to make better results. Obviously, when we are inside of the curvature, we run the risk of breaking the file, and we know this is because the high flexural stress, and we know that the flexural resistance is higher in smaller sizes and tapers and working part. So this is why X7 is perfect for this, because we are using O4 taper. We are using small size from 17 to 25 maximum, and we have a working part which is smaller with a maximum diameter of 1 millimeter. So practically speaking, what happens is that all this heat treatment, especially for the X7, also increase fatigue resistance, the resistance of the file inside of the curvature. So let's say that the heat treatment, the firewire treatment, makes our instrument much more suitable than any other files in a curvature like this. And if we want to once again show the data that we made in our research and we publish, we see that EdgeEndo is not only the most flexible, but is also the more resistant to cyclic fatigue or to flexural stress. So this is quite interesting, but we have to be very honest when we speak about files. What about the torsional resistance? The torsional, the torsional stress are also very, very important in the canal, especially when you have thin, narrow, calcified canal. Here in Italy, we have a population which is quite old, so it's very, very rare for me to treat young patients. I'm mostly dealing with old patients, and the canal, I very rarely see a vital pulp. The pulp, if it's vital, is mostly disappear and mostly calcified. So actually I have to go inside these small canals and open up, so we have a lot of torsional stress. So speaking about the torsional stress, we can measure also resistance to torsion by making the traditional ISO test. And obviously the torsional resistance changes, and this is also quite interesting, but we could talk even one day about this, whether the stress are really present in the instrument, because in all our study, we measure the torsional resistance only at 3 millimeters. But the torsional resistance vary all along the file's working length. And interesting here is that if we measure the effect of the heat treatment on the torsional resistance, we may say that it doesn't really change too much. It doesn't really improve, or it doesn't really decrease the torsional resistance of the file. So this is a quite interesting thing. So you have to understand that our instrument, when we do a heat treatment, increase flexibility, increase flexural resistance, does not increase torsional resistance. But very, very important. This is an example of the torsional resistance between EdgeEndo X7 and ProTaper Next. You see very, very similar results. But very important, what I'm saying is also operative torque, or we can also call it cutting efficiency. What is operative torque? We published quite a lot of interesting studies about this. Is the torque, is the force that we need to make an instrument progress to the apex. So very interesting. We have two graphs here, one from the EdgeEndo X7, the other from ProTaper Next. And we see that the operative torque is very different from one file and the other. So one file progressed to the working length with little torque. The other one progressed to the working length with a high torque. So what does it mean? This could be also a sort of evaluation of cutting efficiency, because a file that progresses more easily, it's a file that cuts better and progress better inside the canal. But also having a low operative torque, it means that we have less screwing in effect, and this is very important because it avoids quite a lot of iatrogenic errors and it reduces the risk of breakage. But also, if we compare the low operative torque with the torque of failure, the torsional resistance, we can make a new test, and we did in this article, we call torque range, meaning that if the resistance of two files is the same, but the operative torque is different, The files with low operative torque, like the X7, has a wider safety range during the clinical use in a complex curvature. So it is quite an interesting point here, because no one has ever evaluated this before. And I think this is mainly due to the properties of the alloy and the design of the instrument. As Dr. Mohamed told you before, please use a lot of irrigant, and I totally agree with you. And we can also demonstrate here is that if you have a file that is full of debris, and because actually a file that cuts a lot creates a lot of debris, so actually if you don't have the irrigant that helps us removing the debris, we will have the file that is full of debris, so the friction will increase and the torque will increase. So as a matter of fact, you may see in two graphs, and to be honest, all the study we make with this kind of evaluation of operative torque are done in vivo on patient. We have a special device that allows us to measure what happens to a file when it goes inside the root canal. Here it clearly shows that if you do not irrigate, you increase a lot of torsional stress. So you make your instrument much more susceptible to fracture. So please irrigate a lot, especially in this complex case. So what we have here is that we will discuss next week about root canal preparation and strategy, and we have to deal with complex apical curvature. We can play a little bit, but actually we cannot modify the apical curvature. So we have to deal with the apical curvature. And we can choose the instrument, and we can choose the most suitable instrument for the purpose, but also we can choose other things in very complex cases. We can choose the motor motion, we can use the sequence, and we can have a different type of clinical handling, which is something that is very interesting, and we will see a little bit later on. Actually, since the heat treatment does not really improve too much the torsional resistance, what we have to do, we have to use a technique that is creating little torsional stress. And this technique we promoted some years ago in 2007 with this article, and we call it Mimerachi. What is Mimerachi? Is we insert the file with a manual insertion, and then we have a minimal engagement, only 1 millimeter or 1 second deeper inside the canal. And then we go out. Even if the instrument is quite free, we don't want to overstress. We want to keep the stress concentrated and very small while we are going inside the curvature. And after 1 millimeter or 1 second, what we do? We remove the file from the canal, we clean the flutes, and you will see that you have a lot of debris. Even after 1 second inside the canal, you have a lot of debris. Imagine how many debris you create if you stay 10 seconds inside the canal and you work and you make your instrument work. And then we remove the file of the canal, we clean the flutes, and we irrigate the canal. So this is the Mimerachi, and we also made some video about this technique: manual insertion, minimal engaging, removal of the file, and cleaning the flutes and irrigate. And obviously with the edge file X7. And I will also talk about this next week, probably about the difference between 2D and 3D, the hidden curvature, and how important is to control the instrumentation stress, how important is to go slowly, step by step, how important is not to increase torsional stress, because our instruments are not, so strong against torsional stress. And the other thing we can do actually is also we can play with the motions. We can play with the motion, we can play with the motors, so we can play with a lot of things. This is an article we published recently in the Australian Journal of Endodontics. We made a classification about single motion and combined motion. And nowadays, so we have a lot of motors that allows us to do quite a lot of interesting motion, or let's say a lot of safer motion. And so let's say that if we have a very, very complex canal, we may decide not to use, for example, continuous rotation, and we may prefer to use reciprocation motion that we all know that it's safer because the files engage and disengage. So it is more resistant to torsional stress, and it's more resistant to flexural stress when it works by reciprocation. And actually nowadays, what I do in my practice, actually, I have a lot of different motion altogether. I don't change the motion because of the file size. I don't change the motion because of file 1, 2, and 3, and 4. No, I only change the motion due to the anatomy. So when I have a more complex anatomy, I may decide to switch to a reciprocation. But be careful, the reciprocation has to be clockwise. So the one angle, the clockwise 150 is bigger than the counterclockwise is 30. So this is totally different from the traditional reciprocation of wave 1 and the reciproc. This is actually the opposite. But you can use this with the X7 file or any file which have these clockwise flutes. So no surprise that when I have a curvature like this, an apical curvature, which is so big, both in MB1 and MB2, I know that there will be a lot of torsional stress here and a lot of flexural stress here. I will go a little bit more careful with the motion and try to select a reciprocating motion. But anyway, since I told you that's when we deal with this complex apical curvature, we have to do a proper management. And as I told you, next week we'll discuss about how to prepare the canal in order to get to this apical curvature. So how we can reduce the stress due to coronal interference, pouch chamber interference, hidden curvature inside the canal. But let's focus one moment now only to the apical sides. So here, as I explained you before, we have to use very flexible Martensitic instrument. We can use them if you want manually operated. We can use with continuous rotation. We can use with reciprocating motion. We can use with combined motion. What is very important is that you have to decide actually how complex is the situation, how complex is the curvature, and then choose your option accordingly. If the curvature is present but not too extreme, you can very easily go step by step, slowly by continuous rotation. If it's very complex, you can use hand instrument. I agree the people who does this, you can also use a glide path file. I prefer to use traditional instrument because I want to keep my sequence very simple, but in a slightly different way with a slightly different motion. So the strategy, since the apical curvature cannot modify it, is to try to eliminate all the coronal interference, to use more flexible and resistance night-eye Martensitic file, the X7. I totally agree we have to use a slightly smaller taper because they are more resistant inside of the curvature, and use safer motion and technique. And if you do this, and especially if you use a pre-bendable file, like the Martensitic file, the X7, you also will reduce the risk of iatrogenic errors because you can slightly pre-bend the file, but also the file itself have less bounce back. So this is very important. Luckily, in the greatest amount of cases, the apical curvature are usually visible on X-ray because they are mainly distally oriented. So you can see here very nicely the curvature, so we know how to manage them. But sometimes, this is a very interesting and tricky case, the apical curvature are not visible, are hidden. This is, luckily, it's quite rare, but when it happens, is very challenging because, first of all, you have to understand that there is this kind of apical curvature. Obviously, if you have a cone beam, it's much more easier. If you don't have, you have to understand that you're not at the apex. There is still 2 or 3 millimeters of complex curvature that you have to deal. And the other thing is that you have to be very careful with confluence and abrupt curvature. But luckily, in this case, when there is a confluence, the case is not too difficult, but it's quite easy because you have to ask yourself a question. In this case, it's more a matter of strategy, and the strategy is which canal first. So you have to instrument when you have a confluent canal, the easiest one to the full working length, and the other one only to the point where they join. So in this case, you avoid very, very complex abrupt curvature that can break very easily your file. So this case looks very nice and actually could be very easy if you do the distal first, the working length, and the other one, as I explained you before. But if you do the opposite, if you start using and try to get the working length with the mesial one, that will be really a nightmare. So what makes the difference here, what makes this nice, it's actually here your understanding of anatomy, your knowledge of what you're doing. And these cases in 3D, I really like. They're fantastic. And I want to show here that these cases look so nice, but they're done only with two night-eye rotary instruments, which are the Edge file X7, the 1704 and 2504. This is what I use in the great majority of my cases. I do a manual glide path, 8, 10, and 15. Sometimes I use a little bit of coronal flaring, as it was suggested before. But when I do this, I use it the 1704 to make some coronal flaring at the very beginning. I don't go to the working length, and then I reach the working length with the manual file. But as I wrote here, additional file can be added, and also glide path file if you like. But in my opinion, this is a perfect sequence because I need a glide path, and I'm getting a glide path with the manual file. Then I have the 1704, which is actually a rotary glide path, or I call a pre-enlarger, that open up the canal for the shaping file, which is the 2504. And due to the extreme flexibility of this file, I can do, and the fact that I'm choosing the right motions and the right motors, it works very nice also in this curvature. So as I told you, in most of my cases, especially when the curvature are not so abrupt, or even if there is a small part of the curvature, what is very important for you, the stress is also depending on the length of the curvature. If the curvature, even if abrupt, is short, like here, only 1 or 2 millimeter, your file will go quite easily. If it's longer, 3, 4 millimeter, there will be quite a lot of stress, so you have to be very careful. And so actually, I mean, in the majority of cases, I can even retreatment of cases, it works very, very fine. I try to use not too much the manual files, because the manual file, I mean, it's a little bit tricky. They have a cutting tip, while the X7 have a non-cutting tip. So the X7 respect the original anatomy way better than a manual file. And if there is a very, very complex case, I may use also an additional file in between the 17 and the 2504. I may use a 2004. And the reason is showing here in this graph that in this case, I have a much lower stress on the 2504. So actually, what we are doing here with the X7 is that we have an excellent strength and flexibility, and this speaks for a great performance. Obviously, it's high technology, it's reasonable price here that we have, but also we have simplicity, because as I told you, this is my usual way of dealing with this canal with only a few instruments, and I'm really satisfied of how this instrument works in very, very complex curvature. I think I'm on time, and I hope that you enjoy this. Thank you.
Okay, thanks, Professor Gambarini, for this astonishing lecture. I think I haven't attended a lecture like this from a while.
Very nice lecture, yes.
We say in Italy, it's always a first time in life.
I think if any GP or new endodontist follow this strategy or these steps in his dealing with managing severely curvature, the exhausting endo will shift it into an enjoyable one, I think.
Well, I saw Dr. Mohammed case at the very beginning, is that that was not a bad dentist, but it failed to manage the apical curvature. It did 80%. Yeah. So actually, the problem with with many dentists is that they have a knowledge of endodontics, but sometimes they miss the slight difference between a normal endodontics and a good endodontics.
Yes.
and probably because they don't know all the instruments. And very honestly, here we have to say that if they don't have the right instrument, they can never make a very complex curvature. It's too difficult for them.
That's true.
Yes, you're right. Okay, now we're going to meet with our third speaker for today. Assistant lecturer in Egyptian Russian University and PhD researcher in University, one of the talented endodontist rising stars here in Egypt, Dr. Mohamed Abd El-Mawla. Hello, Mohammed.
Hello, Dr. Ahmed. Hello, Dr. Gambarini. Hello, Dr. Mohamad.
Hello.
Nice to meet you. Thank you, Dr.
Nice to meet you again, Mohammed.
Thanks. Thank you, Dr. Ahmed, for this gentle word. Before I start, I'd like to thank Perfect Dent for giving me the great chance to be among the meeting with the greatest legend in endodontic field, Dr. Gambarini, and I'd like to thank him personally, actually, because of his valuable published lectures, published articles that I have learned a lot from. When I search for any part in my lecture, actually, I found Dr. Gambarini had many articles published in this part. I changed my strategy in searching by searching by the name of Dr. Gambarini in the article. So thanks, Dr. Gambarini, and it's an honor to be with you in such meeting. And thank you, Dr. Mohamed Fakhr. Really, it was a very nice presentation. I am not surprised because that's what you are used to be usually. So thank you all, and I'm very pleased to be with you today.
Thank you.
Thank you.
Okay, Mohammed, as you know, our topic for today is managing canal curvature.
Yes.
Your topic is you're going to have a lecture under the name of selection of intracanal files for challenging anatomy.
Yeah.
I'm really excited to attend and to listen to this lecture. Are you ready?
Yes, I'm ready.
Okay, Professor Gambarini, thanks a lot. Dr. Mohamed Fakhr, we will meet again after this lecture to have our last part in the webinar, which is the discussion of the topic for today.
Sure.
Okay.
Okay, let me know if it's okay. You are seeing the presentation on the full screen?
Yeah, it's okay. You can switch from slide to another to make sure. Yeah. So we are ready now.
Okay,
we can start.
Now let's start our lecture, in which we are going to talk about selection of proper file for challenging anatomy. The name may be deceiving somehow, because you may think that I'm going to explain, or the main objective of the presentation will be which file we are going to use to solve all the problem and fit all the canals and the challenging anatomy we may face. But actually, the main aim or the objective of my lecture is to highlight the full protocol of dealing with such challenging cases with tough anatomy that we may face in our daily endodontic practice. And as we go or as we proceed in our presentation, we are going to present some clinical cases and explain why I chose a certain file instead of another. Dr. Ahmed, let's agree that the mechanical preparation is not the main aim of any endodontic treatment. Okay, the main aim is to alleviate the pain, to prevent or remove the infection, preserve the tooth and make it to be maintained in the oral cavity, functioning well as much as it can be, or as long as it can be. Okay, and the mechanical preparation, or the chemomechanical preparation, or the cleaning and shaping, whatever we are going to give a name for this step, it's only a step on the way to do a proper root canal treatment to reach this aim or this goal. Okay. In other words,
excuse me, you still in the first slide, or you switch it?
Yes. I'm still in the first slide. I'm just making an introduction for my presentation. No, it's everything is okay. Okay. In other words, what I'm trying to say, or I may emphasize in other words, in an article with Dr. Clark in 2010, categorized the factors that may affect or affecting the ultimate outcome into three main categories: the operator needs, the restoration needs, and the tooth needs. When we are going to talk about the restoration needs, for sure, we are talking about the design or the preparation and how we prepare the tooth to, we can say, for the restoration, or we can get the maximum resistance and the strength for the restoration. But this can be done without giving a great attention to the tooth need. What I'm saying, or what I'm trying to say, that we have to be more conservative and to preserve as much as we can from the tooth structure. We have to focus on giving the tooth the chance and leaving as much as we can from the tooth structure for maximum strength and durability. We may do a perfect root canal treatment with a very good white lines appearing on the X-ray, but eventually this tooth will be extracted or will fail because it's a lack of strength, because we removed a lot of tooth structure. That's why I am talking about or making this introduction, because I'm going now to talk about the coronal flaring, or the first step in any protocol of dealing with not only the canals with the challenging anatomy or rough morphology. Coronal flaring is considered the main step of when we deal with any root canal in general. Okay, we can define the coronal flaring as the coronal modification or the extension of the access cavity into the coronal most portion of the root. We can give the name coronal pre-flaring or coronal modification. The main aim of this step is to remove any obstacle or to give the chance or straight line access of the file to the apical 1/3, or to be more practical or to precise, to give the chance or to give straight line access of the file to the first curvature it may face. Okay. For sure, the coronal flaring is a very, very, very important step because it facilitates all the whole treatment, the root canal treatment, and facilitate the negotiation of the canal and the preparation of this canal. Even we are using manual or rotary files. Pre-flaring also increases the tactile control and promote the removing of debris, which is a very, very, very important issue, and enhanced 3D cleaning because it permits the penetration of the irrigant or sodium hypochlorite as apical as it can reach, so at maximum cleaning efficacy and so on, and also decrease the post-operative pain because it gives the way to force debris to move coronally. For sure, when we say the hydrodynamics, or we are talking about the irrigant and the debris, for sure it will go to the least resistant coronally, the pre-flared or the white portion, not the narrow portion. So this picture is only, I want to say, or to repeat that we have to be more to be conservative as much as we can and to preserve the precervicular dentine. What is the precervicular dentine? It's the portion or the dentine portion that we can say the 4 millimeters above the alveolar crest and 4 millimeters below the alveolar crest. Actually, this portion of the tooth tolerate great forces, occlusive forces, while functioning. So I have to preserve this portion. Not by this, I will reach this, or I want to say that in the step of coronal flaring, I don't have to exaggerate in the coronal flaring and remove too much dentine and make the tooth very weak, and especially in this portion, only to reach the apical 1/3 smoothly and to remove any resistance. No, I have to do it wisely and cautiously as much as I can. Okay, the first step after corneal flaring is the patency and the glide path penetration. We can say the glide path is done, can be done by using a very small files. A K file size 8, K file size 10, and I never say K file size 15. Size 15, we can consider it as a shaping file, not only to negotiate or a patency file. It's a very large file when in relation or regarding the anatomy of the or the severe curvature we are dealing with. I have to use a small file like 8 and 10 to have the print of the canal. I always say that using that small file, 8 or 10, plus the preoperative X-ray, plus the apex locator, you can formulate a 3D image in your brain about the anatomy and the morphology, even when you, CBCT is not present. Actually, the patency and the glide path is done by passing the 10 file or the 8 file, K file beyond the apex, or not beyond the apex, beyond the minor construction of the apex by only 0.5 mm to ensure the patency and the removal of the pulp tissues and debris. Okay, I know that this step especially maybe there may be much debate about it and the post-operative pain and so on. But I'm not going to talk about it. Hope to talk about it in another presentation because it's a huge issue we can talk about. But I'm here concerned with the effect of the patency file and the bit on the glide path. We can say that classify the glide path into micro glide path and macro glide path. Micro glide paths, I mean by the manual files 8 and 10, and maybe with smaller file 6, which I don't recommend to be used by GB or the new dentists because it's too, we can say, it doesn't let any pressure. It may separate and it may do a disastrous situation if it is used inadvertently. Okay, so it's classified into micro glide path and macro glide path. To explain what I mean by micro glide path and macro glide path, here's a video is very informative by doctor using 8 file while negotiating the canal by negotiation motion, okay, back and forth motion until reaching the apex. When I say that I made a glide path, it must be a reproducible glide path. What's meant by reproducible glide path? I mean that file 8 or file 10 must proceed or enter the canal and reach the apical 1/3 smoothly without any motion, okay? Sometimes we put the file and reach the apex, and once you get the file out of the canal and trying to enter it again, so you find some resistance and you need to do some negotiation motion. Okay, here is the glide path is not irregular and is not reproducible. And look to the video, you will get what I want to say. Okay, you are meeting several points or the irregularities. So we reach the reproducible glide path by after reaching the apex with the small file or 08K file. We use 10 file and then we make a gentle vertical in and out strokes as if we are recapitulating the walls, okay, until we get a smooth, gentle path to the apex, or we ensure that we got the glide path. But only we need to do to confirm that, to put the file 10 into the canal, and with a slight apical pressure, it will proceed apically, okay? After doing the micro glide path with the manual files, here I opened the path or the road for the entrance for the rotary file. I never used the rotary file before getting the Canal patent and doing that reproducible microglide path. Okay, only after that I used the rotary. I don't want to name a file specifically, but actually the edge path file is a perfect file. I use it. Actually, I depend on this file in more 90% of my cases because of the nice cutting efficiency. Okay, a very high flexibility, and there's a property that I found. It's a superb property, which is the safety unwinding. I'll talk about later. Okay. After expanding the microglide bus into macroglide bus, here the Canal is ready to receive the sequence of files or what I'm going to do. Doing the glide path also is very important, as it minimizes what's called screw in or threading in effect and the risk of torsional failure. I'm talking about what we what we name a taper lock. What's meant by taper lock? Taper lock if the diameter of the canal is smaller than the tip of the file we are using. Okay, so when we enter the canal with the file, the tip will be engaged or locked into the canal. Small tip, small diameter, while the rest of the file will tend to move or continue the motion. So it will tear, or it will fail or separate. This video I found in a very informative Instagram page showing what I want to say. Here on the right is how the torsional failure or how occur, and on the left video or left portion talking about the cyclic fatigue, successive or alternating compression and tension between the two sides or of the metal here in the video. Let's start presenting some cases, and let's be more practical. Okay, here is one of the toughest cases I have ever met. Actually, okay, I'm very sorry. Okay, here is one of the tough cases I have met lately. I never go for a root canal treatment without analyzing and carefully read the preoperative X-ray. Okay, when we look to the preoperative X-ray here, distally we have a sharp curvature apically, okay, in one root, and there is another shadow, which means another root, okay, in the distal. Okay, here is I was obligated to take another preoperative X-ray with another angulation. Okay, with mesial shift, as you see, okay, I found that I don't only have one curvature apically, but it's a double curvature, as you see. Actually, the first one is nearly 90-degree curvature. To deal with such curvature, I have to pre-curve my initial file or my patency file. This photo of the pre-curved file is only to show you how we can recurve the apical 1/3 or the tip of the file. The curvature of the pre-curving or bending for the tip of the file must be only utilized for the tip or the 1 or 2 millimeters, with not a very sharp bend. We can do the pre-curving by using the orthodontic plier. Okay, some dents, or when they are doing the pre-curvature, they do the curvature at the middle of the file. Once for this curving, our method of curving, when you enter the canal with the file is going to be straightened and it becomes useless. So it's the right to pre-curve the file at the tip 1 millimeter. Okay, at the end, a gentle curvature, or to take the impression, or to take, we can say, to deal with the curvature as you want. Here's two shots for the same case, okay, which I use the X7 and the Edge1, the reciprocating file of EdgeEndo in this dislingual route. I use this file for as I prefer to use the reciprocating motion in such steep curvature or abrupt curvature. Because basically, when we are using the small files negotiating motion, we are using back and forth motion to reduce the stress on the file. On the same base, the reciprocating motion is very efficient in the reduction of the stresses while you are dealing or entering a severe curvature like that. Okay, in such cases, I'd like to only add an info, which is when you see such curvature on the X-ray, okay, you have to evaluate the radius of curvature, which that will tell you how you are going to deal with this curvature. Okay, to use the expression or the radius of curvature is more precise than I'm only saying that it's with a steep angle or an acute angle or the angle of curvature. As the radius of the curve of the circle or of the curvature decrease, so it's become more difficult as shown in this photo. Okay, here is the post-operative of that case. Another case where I used also the Edge files. When you look to this preoperative X-ray, you may be concerned at first with the apical curvature at the distal root. Actually, as the curvature is limited to the apical 1/3, I consider that it can be negotiated and it's somehow simple. As curvature you are facing or you are dealing with go coronally, it becomes more difficult and difficult. But the main issue in this tooth for me was the very long length of the tooth from the reference point to the end. It was about 26.5 as I remember, which means an extra load for the file and a more difficult situation. Okay, here please look at what I meant by the coronal flaring and how it affects your entrance to the canal and remove the any obstacle while you are entering the or dealing with such anatomy. Okay, here's the dentine triangle or the dentine lip coronally found, which I have to remove. Okay, in the step of coronal pre-flaring. Why? Because if you look to the curve or the shape of the file while entering the canal in the presence of that dentine triangle or dentine lip, you will find the curve is severe and especially coronally. There is much stresses coronally. Okay, so you will not feel the tactile sense of the file inside the canal. More stresses, more heterogenic faults, or you may do. So by pre-flaring, a coronal pre-flaring, as the photo you see, okay, look the difference between now the access to the canal. Okay, I know that it's post-operative or obturated, but know the difference in the curvature. Also, as Dr. Mohamed said, when he said that we took the tooth length or measured the tooth length after doing the coronal pre-flaring, because as you see here, the two lines. For sure, the red line is more longer than the blue line. Okay, here is the curve. So after pre-flaring or coronal pre-flaring, your length will gonna be short or shorter. So if you took the length before the coronal pre-flaring, you will end up by over instrumentation. Okay, and here is another case, one very difficult cases I have do lately also. And as I said, the first thing is to interpret or to analyze your preoperative radiograph. Okay, here we see a nearly a 90-degree curvature in the mesiobuccal root of upper 7 of that measures about 27 or 26.5 also millimeter long. It's very tough, by the way. It's very tough case. Here, I prefer to deal with this cases as if it's two different canals. The first coronal portion and then the apical portion. Okay, coronal pre-flaring. In such cases, I use the reciprocating file and the glide path. Okay, but I'd like to add something. Some dentists use a picking motion to deal with or to enter such curvature. Picking motion like the woodpecker, in and out, in and out, in and out. I'd like to add that, okay, picking motion may be helpful to deal or to face the curvature, but you have to do this picking motion carefully and with a very low frequency. Okay, a new paper, I think it was published last year, it showed the relation between the frequency of the picking motion and the failure of the rotary instrument, and found that the low frequency is accompanied by more resistance or less failure in the instrument used. Okay. And this case, maybe the last case, it wasn't that tough case when we are talking about the curvature, but actually not every day we can face an upper 6 with that upper first molar with such morphology, with 6 canals like that. As you see, each canal is wide, and each canal is prominent. We can say. So here in that case, I used the edge file X7, okay, to deal with the curvature. It wasn't that hard curvature or tough curvature in the distobuccal root, but actually I used the EdgeEndo file X7 lately, and I am surprised with the cutting efficiency and the excellent property which I mentioned before, which is the safety unwinding. I recognize when I'm using the edge file that the file dealing with the hard curvature, the file is unwinded, but in the coronal portion, not at the tip. And when you get the file from the canal, you see that unwinding. Okay, it's a good sign, or it's an early sign to discard the file before being fractured or separated inside the canal. Okay, but it's if the unwinding happens, it happens in the coronal portion of the file. Okay, and it continue to proceed, getting closer to the tip without separation. And I recognize such property or such behavior in very tough cases. Maybe I didn't present in my presentation. Especially, I can remember a tough case. I was dealing with a very narrow MB2 with a severe curvature. Okay, I was astonished by the cutting efficiency and the flexibility and of the edge path file. Okay, I hope that it was informative and I wasn't that boring. Okay, thank you, Dr. Ahmed. Thank you, Dr. Gambarini. Thank you, Dr. Mohamad. And thank you, Prof. Dent, for giving me that great chance.
Okay, thanks, Mohamad, for your efforts, and thanks for this lecture. I think after watching this lecture, I wish to become one of your patients, Mohamad, with this perfect observation and these 6 canals. Okay, thank you all. Now we are going to shift to the second part of the webinar, which is the discussion about our topic today under the title of managing canal curvatures. But let us first see this interview with Dr. Mohamed, the founder and CEO of the EdgeEndo company.
Can you give us an overview of EdgeEndo's leadership in the industry and what makes your product stand out?
Design and also our heat treating method. We've spent a lot of time trying to create geometrically the best instruments out there, and then our heat treatment process allows it to be the most flexible and what I believe the safest instruments in the industry.
And can you tell us about some of your key products? How do they work?
Yeah, our favorite products are the X7, then also the Edge Taper Platinum, and then the Edge One Fire. They've been incredible endodontic instruments for everyone in the industry, and they're helping patients and dentists do the best they can.
Oh, excellent. And Chuck, how did dentists benefit from using your product line?
I think the flexibility and what allows them to do the best work that they can do in a quick and efficient manner for the patient.
Right. And what about the patients? How does EdgeEndo, how does that improve the outcomes for people who are undergoing dental treatment?
Our costs are probably half to a third of everyone else's, and that saves money for the dentist and it helps save money for the patient.
Great. Chuck, how does EdgeEndo ensure that each product is of the highest quality?
There are numerous, up to 20 different checks to make sure that our instruments are fantastic and perfect, what we believe every time.
Great. And so we're used to premium products coming with high price tags. How is it that EdgeEndo is able to keep the costs down for dentists?
Unfortunately, in the industry, there tends to be a very, very high markup, and I didn't want to do that. Being an endodontist, treating patients, seeing how high the costs were, we can still offer a great product, but at a half to a third the cost. We just don't need to charge as much as everybody else is.
Okay, we are back. I think it's a revolution in the market of the endo. One of the reasons that endo files become in this endo market and takes its reputation is that the founder is the specialist, an endodontist. So I think he spent a lot of time searching for the best geometrical outline and searching for the heat-treated procedures. And also he has a lot of reasons to help the dentist to play with the files that is safe and they have a high efficiency and very flexible. So also for the price tags, he tried or he succeeded to get the dentist use these files with reasonable prices and give the best services to his patients. Okay, now we will start our discussion. I will start with Prof. Gambarini with some questions that we see in our Facebook page. First question, Doctor, is as a legend in the endodontics, Professor, of course you tried a lot of endodontic files. What do you think the differences between EdgeEndo files, especially, and any other files you used before?
Well, in my lecture, I very briefly mention
نعم. So I think we have.
And I think that's this makes the difference.
Professor Gambarini, excuse me, you were disconnected.
Where the connection? Okay, yeah.
Yeah, I will ask you the question for the second time. Sorry.
No, I got the question.
Okay. So you can answer the question from the beginning, please, Professor.
Yes. I mean, all the data I presented today, they are published or they are undergoing publication. So, I mean, the good quality I show today, it's evidence-based. And we did quite a lot of research about this. And also we did quite a lot of innovative research. If you have to ask me which is the key secret of Edge, in my opinion, is the heat treatment. Because heat treatment is very complicated and you can make a lot of heat treatment. What Chuck made very nice, and because we know this because we tested, and some of the heat treatment we tested, weren't as satisfactory as the one that are now commercialized. They are great, they are superior than any other competitors by far. Because with the heat treatment, it's very tricky. When you can change something, it may affect other things. So it has to be very, very precise and that kind of heat treatment. And it's very, very difficult to duplicate or to copy. Let's say it's easier to copy a design. It's much more complex to copy any treatment. That's why I think, in my opinion, yes, Firewire and Edge is so unique.
Okay, I think also this Firewire let the files be high flexible files and very difficult to be fractured, I think, also.
Yes, the Firewire treatment makes them, as I explained, more flexible, making less heterogenic errors because they have less elastic memory, less bounce back. It keeps their cutting efficiency, and also it increases quite a lot the flexure resistance and reduce the operative torque. So actually, I would say it improves 90% of the idle properties of the file, while other competitors may improve only 20-30%. Let's put it this way.
Okay, that's great. The question for Dr. Mohamed Fakhr, as you told us in your lecture, that sodium hypochlorite has a great advantage in the curved canals. So we have a question here. What about ADTA or gel creams formation in managing curved canal? Does it have the same effect?
Now, as I've just said in the presentation, according to the literature, EDTA gels and creams results in great stress on the rotary files and results in great torque usage, and it actually might result in fracture. Again, as I'm saying, I consider sodium hypochlorite to be a close friend of mine. He is my friend when I'm doing my root canal, and the activation of the sodium hypochlorite, especially in an upward and down movement, its activation, it dissolves the tissue very well, dissolves the collagen fibers, and allows you to prepare the root canal much better in the apical curves. So gels and creams and pastes with EDTA actually results in greater amount of stress on the file. So the aqueous solution of sodium hypochlorite is much more better.
Can I add something to this?
Yes, sure.
Because this is a very, very important topic, and I totally agree with Dr. Mohammed. And this is a big misconcept. When general practitioners, they have difficulties in progressing with the file, they think the problem is the lubricant,
yes,
which is not correct. Actually, the problem is different. Mostly, in my opinion, it could be calcification, or it could be a hidden curvature or a curvature. And they are using a rigid instrument. Now, if there is a calcification, which is, a possible use of, a chelating agent, the risk is that if there is a calcification at the very beginning or in the apical part with a curve, and then you force, by using a chelating agent, you may run the risk of perforating the canal and not following the correct anatomy. In most of the cases, I totally agree with Dr. Mohammed that the use of chelating agent is totally useless, and sometimes it may lead to mistakes.
And you know, Dr. Gambarini, when I say things like that, a lot of times I find myself saying it alone. If you get really, if I get 100 people that are working practitioners, they tell you, how is that a calcified canal EDTA chelating agent is the answer? How don't you use it? You have to use it. So this is a great misconception that is out there, that I wish that it would disappear. Yes.
Yes, and obviously we also are currently making some studies on new irrigants, and also we are evaluating the properties of sodium hypochlorite as a lubricant. It works very nice as a lubricant.
Yes.
No need for ADT. So.
Yeah.
Sorry. Well, maybe someone wants to sell ADTA, but okay.
Yeah.
So, in this case, you may need a DX.
Okay, Dr. Abd El-Mawla, some dentist of our followers is asking, what about C+ files in such curved canals? Do you recommend C+ files?
Actually, I'm afraid to answer this question in the presence of Dr. Gambarini. But okay, when you're talking about file, I don't recommend the usage of C+ file from start with such curvatures. You know, C+ file is characterized by being more stiff or stiffer. Okay, so when I am dealing with such tough cases, you can say that you have to deal with the curvature as if it's lady, okay? Never to do or to use extra force, okay? Never to use the C+ file. Really, I'm not joking. I'm talking because the C+ file, okay, is of greater importance, and you can use it when you have a very narrow canal, or you can say calcification. But I can't use C+ file from the beginning in dealing with such cases, okay? Because it's more stiff. That it's my personal opinion, and I don't know if I'm true or no.
If I may say something, you are perfectly right.
For sure.
In my opinion, this kind of file is a shortcut against some problems the dentists find. But actually, when you have a problem in scouting with a small K file, the only thing that you can do is instead of using a more stiff file, is to enlarge a little bit coronally, as was suggested by all the speakers. You have to make a little bit easier the life for the manual file in the coronal and middle part, so they can follow more easily. So as I say, you have to be gentle in the apical part. If you try to be hard, sometimes you may get to the working length, sometimes you can make iatrogenic errors.
Yes, for sure. That what I meant, because when the new dents or junior dents ask about C+ file, they are using the C+ file, and they want to reach the apical 1/3 from the first time, and they continue negotiating, and push and doing some forces on the file. That's true. That's what I meant to be, and it's a very valuable ad, Dr. Gambarini. Thank you.
Okay, Professor Gambarini, another question is, you said in the lecture that you recommend using K manual file 15, then 17.04 taper,
yes.
X7, then 25 X7. So the question is, do you prefer also to finish the wide canals like distal or palatal canals at the same taper and apical size?
Well, interesting question. Actually, I will answer to some of this question in the next lecture next week. So we give some suspense and some expectation for the next lecture. But actually, okay, this is a little bit weird concept. I'm not extremely in favor, especially in complex curvature, to enlarge a lot of the apical sizes. Actually, in a complex curvature, the apex is normally very small. We have big apex, we need big instrument only in easy case or in easy medium case. So obviously in easy medium case, I may decide to enlarge more, touch more canal and walls with a bigger file, but this is not the case. I mean, the topic today was management of complex apical curvature, and in this case, I mean, if you go to a 25, it's a huge success. If you want to go bigger, you can try, but you have to be very careful. As a matter of fact, I mean, also Dr. Mohammed, if I remember, he was using number 20 or 25 as a suggestion. If you go bigger, or 4. If you go with bigger taper or bigger sizes, you are dealing with very rigid instrument. And I'm speaking, and I'm using the most flexible file available on the market.
Yes.
Okay.
So,
Dr. Mohamed Fakhr, why don't we use 515 from the beginning? Is a question.
You will need to use a little bit of a smaller files at the beginning. You will use file 15. You will use it. However, you will need to use some smaller files like the K file size 8 and the file 10, because file 15 from the beginning in an extremely curved canal, it will be hard to advance to the apical 1/3 with it. So you will need smaller files to negotiate such an anatomy. And to add at this part, you will need file 8 and file 10 to be stainless steel, not nickel titanium, because nickel titanium files will not be able to cut through and penetrate through the canal. So small file size 8 and 10 that you need, you might need them to be stainless steel better than night eye files, the manual files.
Okay, and does the canal flaring decrease the mishaps by this degree?
The coronal flaring?
Yeah.
Yes, the coronal flaring reduces procedural errors a lot. It reduces the stresses apically on the file. You will not need to flare the coronal portion much, okay, but to a certain degree to allow you to reach the apical curve within the root canal to prepare it. However, and this part is important because there are a lot of studies that are comparing the coronal flaring with different rotary instruments and with the Gates Glidenburgs, for example, and according to the efficiency in the in night eye orifice openers, they did not find that statistical difference on the fracture resistance of the tooth. However, for example, for Gates, when a clinician uses Gates to flare the coronal portion of the canal, they found that the fracture resistance of the tooth decreases considerably. So using Gates for coronal flaring might weaken the tooth that much, and at the end, by time, it might lead to vertical root fractures, cracks, and so on and so forth. So to a degree, coronal flaring, not much.
Okay, here is the last question for Dr. Mohamed Abd El-Mawla from Dr. Min Ashraf. He realized that she doesn't feel the tuck back action in several cases with apical curvatures. However, X-ray shows that the master cones reach the working length. Well, is this normal or she has a problem?
Okay, well, there is some misconception right here when we are talking about the tuck back. Okay, that may need to talk about the false tuck back and the true tuck back. But if the question is that she doesn't feel the tuck back apically, okay, here it's about the file itself she used. Okay, there is a misconception that the rotary files we can use a rotary file with the greater taper, so it's much bigger or larger than the manual files, and that's not true. Okay. Also, the rotational motion, or sometimes when she uses a rotary file, stiff rotary file, this file tends to regain or restore its shape. Okay, so it's make the apical preparation, or that's the apical stop, not that around the cross section, or okay, it's do some, we can say zipping. Okay, so here again, to ensure this, okay, first of all, we have to follow the steps of entering or proceeding to the apical preparation cautiously. That number one, and number two, to check the gut pressure itself. Sometimes there's a difference in the same gut pressure codes in the same package.
Okay. That's
if I may say something, I've been lecturing for 20 years and making courses about vertical condensation, so the importance of the tuck back and the matching of the gut aperture cone, the instruments, and all these problems. In the last few years, I've been switching to cold bioceramic techniques that have no longer to make this kind of explanation. Everything is much, much easier. So I think, I hope in future we will go to a much more simple and efficient way of doing the operation.
Dr. Gambarini, in this part, you mean that you use, for example, if you finished preparing the canal with a 25.04, for example, file, would you use the master cone? Would you use 25.042 with the bioceramic sealer, and that's it?
Yes, actually, if you think about the bioceramic sealer, the cone is not the obturation. The cone is only a carrier, and the cone is only a path for retreatment. So if you stay ½ millimeter short, 1 millimeter short, 2 millimeters short, doesn't really make any difference. So,
okay.
So it's much, much easier, the cone fitting, the master cone fitting. And actually, I'm using, because of this, I keep the cone 1 millimeter, 1.5 millimeters shorter. I'm using a 25 or a 2004.
Okay, and you apply the bioceramic sealer with the syringe directly within the root canal?
Yes, the syringe directly, half of the length of the canal. That's so easy. Maybe okay. Maybe I can show this, but it's a sort of piece of cake. No, I'm serious. It's a great technique, especially in these difficult cases we show today. The cases that you show are so nice in terms of preparation and shaping. You did a great work, but actually this is not only the work, but because these are very difficult canals when you have this kind of very complex curvature to obturate. So I think that with bioceramics, the filling is way easier than any other technique. So this is a good advantage.
Yes.
Okay, here's we finished the discussion and the questions, but before we say goodbye, we want you to share with us the name of the winner for the voucher of today. I will take one paper, have the okay, here's Dr. Sarah Hassan Mohammed. Sorry, Dr. Sarah Hassan Mahmoud is the winner for today. Please, Sarah, contact the Facebook page, doctors on the Facebook page. Thanks for you all. It was an honor today to meet all of you. Professor Gambarini, thanks a lot. We are going to meet next Friday for the second webinar.
With a lot of new things.
Yes, with a lot of new things, but we're
very happy for next week.
We're very happy, Doctor, for this webinar.
No, thanks to all of you. Thanks for the organization. That was great. And I think the quality of the whole presentation was extremely high, and compliments for all the lectures.
Yes, because of you are with us, the professor.
It was a pleasure to meet.
I only did 1/3.
Okay, thanks, Dr. Mohamed Fakhr, lecturer of Endodontics, ERU University, for such a great webinar and great lecture. And thanks for Dr. Mohamed Abd El-Mawla, assistant lecturer of Egyptian Russian University. Thank you all for watching, and we hope to meet next Friday with another 2 speakers and with Professor Gambarini and a lot of surprises from Perfect Dent. Goodbye.
Thank you. Goodbye.
Ciao, ciao.
Bye. Yeah, bye-bye.